We'll start in 2 minutes. 4:20, so just making sure that we'll be on time. Okay, hello everyone. My name is Ekhtiari. I'm delighted to be here. And we are going to have a panel discussing about the recent advances in ISAM Global Expert Network and the initiatives that we have in this regard. So we will have 6 speakers today discussing about new advances, and we will be chairing that session at the end with Atul and Marc. And my lab in University of Minnesota is mainly designed to develop new therapeutics for addiction. So we use different technologies, we use different brain stimulation technologies. These are my core team members in University of Minnesota, and we try to see how we can develop brain stimulation technologies for addiction treatment. This is one of the new works from my lab that ended up to the cover of American Journal of Psychiatry in February this year. And we have been discussing about how to target different areas that are going to be important for addiction treatment with different technologies. So we optimize the way that we can target different areas in the brain, and we use robots and robotic arms to optimize the stimulation in a way that we can do that in an individualized way to find the right target for each individual patients. And also we develop brain rehabilitation interventions, different versions of different brain rehabilitation interventions, also brain awareness material for people in the process of recovery. You can find them when you Google for brain awareness for recovery initiative. And some of these materials are being translated in 22 different languages. So people around the world are using those materials. And we are really interested to bring new brilliant minds to the field with what we call In Love with Addiction Neuroscience lecture series. So we have invited a group of people, and we have been running that series of discussions online. So that is what I was doing initially with ISAM, kind of shaping what we called ISAM Neuroscience Interest Group and pushing things forward. And then pandemic happened, and my lab was closed. Many of our activities, they have been shut down because of the pandemic. And we realized, oh my goodness, things are pretty complex around the world regarding addiction treatment. And we started to realize, okay, it seems that we need to work together. We need to help each other in the process of pandemic. So we started to ask people around the world about their experience regarding the pandemic and how they are dealing with the pandemic during that period of time. So we invited experts from 77 different countries, 177 experts, and this is a distribution of experts. And we asked them about how they are dealing with pandemic in their addiction treatment services. And Dr. Farhudian, who is already here, he was leading that activity, and we have been able to bring people online, in online platforms, to collaborate on that regard. And we realized about the potentials. We published several papers out of those discussions and having a good idea about, okay, we can run global activities, we can run global surveys in that process and bringing people together. And we started to realize that we can do more with those sort of network activities. We realized that we can have global questions to be answered with that sort of global networking activities regarding demand, supply, policy making, and we started to think, okay, we need to formally shape that activity in what we call ISAM Global Expert Network. We design the processes in ISAM Global Expert Network, define the pipelines and processes and terms of reference in terms of how that global activity is going to happen. And we realized that we can develop networks with individual experts, with societies and associations, also with treatment centers around the world. In the first round, we have been able to recruit 354 experts in 2023 in a sort of validated way, and this is a distribution of experts we have around the world. And also the blue one is the societies that we have which are involved in that process. In 2024, we extended the network, and this is how you can see the difference between 2023 to 2024. So we extended network, and these are the experts that they have validated profile in terms of their expertise regarding the substance use disorder around the world. And this is the shape of the network that we are working around the world. And then I was appointed to be initially the co-chair and then chair of the ISAM Regional Council. And when I basically took over the process, we had some 6 regions around the world, and most of the time the ISAM board members, they have been running those regions. But we basically pushed things forward, and we divided the world into 15 different regions, and we defined regional representatives for each part of the world, each of these regions. Now we have the full council of regional representatives who are working in different areas, and we are also working with addiction medicine societies, also national ambassadors around the world in that sort of structured network of collaborations. As you can see here, this is one example of one specific region in the world. In West and South Europe, you can see that we have national contact person in each country around the world, and each national expert, they have at least 10 experts in their network. So we develop a global network of point of contacts around the world. I mean, there are areas that we have, most of the countries are being covered. This is what we have in North and Central Europe, and as you can see here in South America, and I mean other places around the world. And these are the societies that are already working with that global network and how people are collaborating. So we had our first Global Assembly of Addiction Medicine Societies in Malta, the second one in Morocco in 2023, and just 2 days ago we had the third one in terms of the in-person meetings in Istanbul here downstairs, and we had the meeting and the discussions here, as you can see here, as a pre-conference event. So we are pushing the idea forward to have what we call World Addiction Medicine Reports. The idea of developing a network of colleagues that they can collect information around the world and putting them together in what we call World Addiction Medicine Report. And this is the protocol paper, how that works. We developed lots of workshops and educational materials for those who are interested to learn how to use global surveys. If you follow ISAM YouTube channel, we put all those videos, so we have over 100 videos there that you can use in that platform. Meanwhile, we develop a specific roadmap to run global surveys around the world and collecting information and publishing the results to be able to have an idea what is happening in different parts of the world. We already have 5 working groups working on substance-induced psychosis, problematic use of internet, ADHD, substance use disorder comorbidity, telemedicine, PTSD, and substance use disorder. And we are here to invite you to shape the new working groups within this global network. And we have a series of speakers today from those who are very senior in the field, like Christian Schuetz, who is a full professor of psychiatry, University of British Columbia, to recently graduated medical students who are working together in that network. So that is what I love about this network, because people are working together from different levels, and you will have their presentation today. So we received IRB approval from different universities, including the University of St. Andrews, so the protocols are being developed, and then we are also working with different networks like ICASA, specifically on ADHD and substance use disorder, and we are inviting others to join that network. So you can just basically use your phone, kind of scan the QR code. You can just check if the QR code works right now. If you are not already a member of that network, you can just basically, is it working? Is it getting you connected to a, okay, Arash, do you want to, I mean, anybody who has phone, you can just check if the QR code works. So you can basically apply and add your information in that network, and if you are interested, we can have you in that network. And now we are developing a specific portal to have everybody who has been validated as an expert in the field of addiction, they will have their own profile in the portal. And they receive surveys in the portal, they receive kind of feedbacks in the portal, and it's a cloud-based portal. It runs the online surveys. Basically, we do data analytics there. There is a user management. There is a scoring system. So every year we rank those who responded faster to the surveys and giving them kind of stars and ranking them based on the quality of the responses. And also we added that to the membership process in a way that those who are more active in the field, they can receive discounts in their membership. So we just try to make an integrated system. We already work on the portal. There is a living document, so those who are interested to be a part of the process, please approach us and we will be happy to get you engaged. So we will have a series of speakers today who are going to present different activities that we are doing in these networks. And I'm really happy that we will have them here today, and hopefully we will have lots of exciting discussions. And hopefully after the panel, you will be encouraged to join us and help us in that process. So the next speaker, who is going to be the next speaker? Fateme is going to be the next speaker discussing about opioid use disorder survey, one of the pilot surveys that we have done. Fateme, please.
Hello, everyone. This is Fateme Abolghasemi. I am a medical doctor, recently graduated, and currently working at the emergency department, and also ISAM-GEN assistant officer. And today, actually, I'm here, I'm honored to be here to be giving a brief report on global survey on treatment service provision for opioid use disorder on behalf of the excellent team we have. As Dr. Ekhtiari mentioned earlier, he gone through an introduction to ISAM-GEN and ISAM General Council, and I'm gonna continue the discussion with the pilot survey that is mentioned in ISAM-GEN protocol, and survey methodology, survey results highlights, and the road ahead of us. As mentioned in the ISAM-GEN protocol, it actually secures a structure based on which ISAM-GEN surveys are being ran. And for the first attempt, we actually decided to run a pilot survey to see how the processes are going to go through, how the challenges we're going to face, which platforms works best for us, if the type of questions that we'd rather ask people to be answered. And for that first attempt, actually the topic we chose was initially a universal prevalence issue of concern, which is opioid use. With actually more concentration on treatment service provisions globally all around the world. This survey is designed in two distinct phases. The first phase is the survey with contact population of addiction medicine societies, chairs, or representatives. And we're hoping to run the second phase of the survey with a target population of ISAM-GEN individual experts that we have in our database, which is actually at the moment kind of like about 500 people. Going through the methodology, first up, we had to initiate the questionnaire. The way that this questionnaire is formed is like we have this ISAM-GEN steering committee, which is which are the people who are holding more of the scientific aspects of initiating the questionnaires. And after their brainstorming and giving the ideas, this initial list is given to ISAM-GEN officers. They process it and implement the ideas and concepts. And then it's like back again to the steering committee. They give their comments and viewpoints on the questionnaires, and after the questionnaire is finalized, the first people who are responding to the survey to ensure its reliability and stream of components are ISAM-GEN officers again. And here in this slide, you can see an overview of ISAM-GEN steering committees with more precise facial details, and also ISAM-GEN officers in here. Going through survey questionnaires outlines, it actually consists of kind of like 5 domains. It was first like, it starts with demographic questions from the experts, and then we go through prevalence of opioid use, and then opioid use disorder treatment, opioid use harm reduction, and last but not least, survey contribution rate. The target population in this survey, as already mentioned, is like addiction medicine societies chairs or representatives. The thing is, as Dr. Ekhtiari mentioned, there are 3 target population within ISAM-GEN that we reach out to collect data from, but for this pilot survey, it was like addiction medicine societies and associations. The platform actually we used to collect this data and information from people was Google Form. And as, again, Dr. Ekhtiari mentioned, we are hoping, actually, we're at the very final steps of developing ISAM portal so that experts could be engaged more in this survey process, and as Hamed mentioned. Before the start of the survey, there's this consent form, which includes what does the research involve, why they were chosen for this research, and etc., as to ethical considerations. And after experts filled the consent and was like they're into filling the survey, the invitations and reminders were sent to Addiction Medicine Society's chairs, which were actually 42 societies and organizations from 39 countries. The initial invitation was sent on July 2022. 8 reminders were sent afterwards, and the final reminder was on March 2023. And here there's this overview of the map of actually ISAM-affiliated societies who were collaborating in this pilot survey that was ran. And here you can see just more details of the things that were done behind the scene of tracking and reminders and all those kind of things. And now I'm going to go through a brief report of the initial results of the survey. First, I'm going to start with varieties of opioids in the market. It was reported that prescription opioids and heroin are reported to be the most used opioids in general, with tramadol and codeine being the most reported among prescription opioids themselves. On treatment types, short-term medically managed inpatient withdrawal and self-help groups like Narcotics Anonymous was the most reported available treatment for OUD worldwide. But the thing is, less common treatments like long-acting naltrexone maintenance and rapid opioid detoxifications were not widely available. This thing suggests that the need for a broader range of treatment options that cater to different individual preferences and socioeconomic status. Going on with treatment medication types, opioid maintenance treatment with methadone, buprenorphine, and also oral naltrexone were reported to be among the most prevalent medications used for opioid dependence treatments. But the interesting point, which was actually not very interesting, was that despite the prevalence of opioid use disorder, 16% of the countries reported no availability of methadone, buprenorphine, or morphine essential medications for opioid use disorder treatment. Moving on with treatment settings, Overall, community-level outpatient clinics, inpatient settings, and long-term residential programs were among the most available treatment settings that were treatments were done, and shelters were among the least available treatment facilities among opioid treatment settings, which was actually more prevalent in Europe. Moving on with psychosocial intervention types, all countries except for Iraq reported the availability of motivational interviews for OUD, and still the very most of the countries again reported cognitive behavioral therapy and family therapy as available psychosocial interventions respectively. Going on with 12-step programs for opioid use disorders, less than 75% of countries reported a national-wide availability of 12-step programs, a widely used support mechanism, while the North American and Oceanian countries have all reported almost nationwide availability of these reports. Opioid harm reduction services, where countries reported HIV antiretroviral treatment, HIV testing, tuberculosis, and sexually transmitted infections diagnosis and treatment as available opioid harm reduction services. And moving with opioids harm reduction settings, in terms of available settings, in-person treatment centers, drop-in centers, and outreach teams are reported to be among the most available harm reduction settings in which harm reduction services are provided. And last but not least, 76% of the countries reported HIV treatment programs availability, followed by 67% for HPV and HCV treatment programs, with the support by the health system of almost all patients with OUD. And again, my slides are at the very end of it, but the big question is how we could contribute. We are eagerly recruiting addiction medicine experts from all around the world. You could scan the QR code, and then you will be soon involved in international collaborations with us, with actually within the ISAM-GEN networks. Thank you.
And we are keeping the questions for the end to have an overview about the entire picture of ISAM Global Expert Network. The next speaker, Arash, you are the next speaker. Joe is the next speaker. Joe, please.
Good afternoon, everyone. Thank you for the invite to be here. It's my first ISAM. It's absolutely amazing. I'm an addiction medicine PhD student at St Andrews in Scotland, and I wanted to give a sense of the kind of results and the kind of engagement we can get from these national projects. And I'm going to be reporting some initial results from the survey around the people's experiences of telemedicine for opioid use disorder treatment. I'm presenting on behalf of myself and the principal investigator for the study, Dr. Joe Tay, who's over in San Francisco at the moment, so can't be with us. I'll give a brief introduction and background, outline some results from the survey, and mention next steps. And a quick warning, I'm going to be seeking support and engagement from people to be involved in a follow-on Delphi study if anyone's interested. So get ready for me giving a big push to that opportunity. So as we all know, opioid use disorder is a significant driver of mortality and morbidity among people who use drugs. We're all well aware of the ongoing drug death crises in North America and Europe, especially Scotland. And despite there being evidence-based medication, as Fatima's slides that she just showed, I was astonished to see countries where some basic medications for opioid use disorder aren't available. We know there are treatment gaps. Telemedicine to deliver opioid use disorder treatment involves using audio or video consultation techniques, and through which we can diagnose prescribe medications, and offer people treatment and support and motivation to address their addiction. There's been a large amount of interest and some activity in publications on telemedicine for medication for OUD during and post the COVID pandemic. And in general, this work's coming out of North America. Can we do something to make it a little more equitable and get opinions and experiences from around the world? We shall see. And so TMOOD, as I'll abbreviate it, has real potential to reduce barriers to access and engagement to treatment and address that treatment gap. So there are some key research gaps. As I've mentioned, the bulk of the evidence comes from some really valuable experiences across the USA and Canada, but there's a dearth of information from around the rest of the world, especially countries that the World Bank classes as low and middle income. There's also a lack of guidance on how to deliver safe and effective treatment over video and audio links. This is a real barrier to uptake and delivery of such services, and again, something we need to understand better in order to address. So this study, undertaken through the ISAM-GEN program, there are two parts to it. The first is nearing completion, and there are final opportunities for people to get involved and give their views if they wish. And it's an international survey to understand people's views and experiences of TMOOD. People were eligible to participate whether or not they, their service, their region, or even their country are currently delivering this or not. So this survey is not just about how do you do it, but it's about do you? If yes, how? And if not, why? So we've tried to be quite encompassing of people's experiences. The follow-on work we'd like to develop is developing some jurisdictionally relevant guidance through a Delphi process to develop consensus on best practice in delivering TMOOD. And today I'm going to share preliminary results from the initial survey. So as of the 1st of September, we had 42 participants. Since then, that's gone up to, I think, 55, so this is increasing day on day. We have representation from 28 countries. As is a real strength of ISAM, it's not limited to English-speaking, developed or high-income countries. We have representation from all continents in the world. Sure, the majority of responses, nearly half, are from what are classed as high-income countries, but crucially, we're getting the experiences of people in a wider range of settings. Maybe reflecting the ISAM-GEN membership, of which I'm one. It's a slightly older age group of participants. And again, reflecting the ISAM-GEN membership, possibly, of which I'm one, predominantly male. So we definitely welcome a wider range of age groups, and especially our female respondents. So we asked people about current use of telemedicine in their country or jurisdiction. A quick aside, you might wonder why I talk about country and jurisdiction, and it's because we wanted to be mindful and respectful of the fact that in some parts of the world, a country might have a national policy that affects practice across the whole of that country. But thinking about maybe, for example, Canada, you've got some centralized policies and guidance, but then there are very different opportunities and ways of practicing in different jurisdictions, so hence the distinction. So we asked about, was there any use of TMOOD before COVID? And just over half of places there were. Was this more common following COVID? Massively so. So clearly the pandemic was an opportunity and a driver for this method of treatment delivery. So I wanted to highlight those in particular as being relevant, and I won't speak in detail of the others, just to say that over half of countries and jurisdictions had some guidelines for general healthcare delivery over video and audio links. but much less experience of being practices in place for clinicians and services to be reimbursed for that method of delivery, and whether that reimbursement excluded audio only and required video consults. And another thing to highlight is thinking about barriers. Okay, there may have been some team mood before COVID, and it may have increased during the pandemic. However, 60% of participants said their guidelines exclude controlled drugs, i.e. exclude the ability to prescribe and monitor evidence-based treatments for opioid use disorder. So we're seeing a bit of a tension between the ability to have contact with patients and the ability to provide the kind of interventions and treatments they need. Just to say, when we asked about whether there was any telemedicine for opioid use disorder before COVID, we saw, the pointer's not working, the bottom part of the chart is responses from low and middle income countries. The green column is yes, and we wanted to highlight that we are not just seeing experience of team mood in high-income countries, we're seeing it across a wide range of settings, so this genuinely has potential to be a global series of interventions to reduce barriers to access. So thinking of barriers, we asked about clinical system. These are the top 7. There were 23 in total. I'm going to show you the top 7 and the bottom 7. We thought it was significant that the most commonly identified barriers were associated with systems. The ability of clinical systems to manage that method of service delivery, guidance from organizations, support from people with power, incentives, and drug monitoring. So the majority of the most common barriers are system-related, and despite what maybe the literature suggests, despite what some conversations I pick up on, actual clinician-led barriers of lacking experience and training and feeling that assessment isn't possible aren't the most common. The main barriers are based within systems. Thinking of the bottom 7 of barriers, okay, 41% of clinicians think that there are real issues regarding the safety of delivering treatment for opioid use disorder via telemedicine, and that's valid given the concerns around not only potential toxicities of the treatments and about issues of people continuing to use substances, but also the safety of the quality of interaction they have. So yeah, one of the highest of the bottom 7 barriers does relate to patient safety, maybe suggesting there is a need for some evidence-based guidance. Clinicians highlighted also communication difficulties. Do we have the same quality of interaction with patients when it's just done over the telephone or a Teams or video link? And finally, we wanted to flag it was the very bottom identified barrier, but there were perceptions it increases workload, and in some qualitative work, clinicians told us a real challenge is that sometimes video consults were being squeezed into what would otherwise be downtime, and there can be a little bit of creep where they were seeing patients out with dedicated clinic times. Another reason we've highlighted these are, sure, these are important barriers that we need to understand and address, but these are also the barriers with the highest number of grey, undecided responses. And it's important to focus on the clear yes and no's. It's also important to understand where clinicians are undecided or unsure. Again, is there more work we can do with research, with consensus development and guideline development through ISAM to reduce the undecideds? Many clinicians have got little or no experience of delivering T-mood. How can we make that a safer and more comfortable process for both clinicians and patients? Again, I won't go through all the country-level responses in detail, but I did want to highlight that one of the barriers we asked about was, is lack of patient demand a barrier? This means, are patients not interested in having telephone and video consults? And you'll see the purple column, where respondents disagreed that was a barrier, is the most populated. And that applies whether you're looking at high or low and middle income countries. The message is clear. Clinicians believe that their patients find this an acceptable and accessible means of engaging in treatment and care. So we can do away with the myth that, well, patients prefer to come in and see us in person. Patients, it seems, are asking for that choice. So takeaways. It seems there is a significant demand for audio and video provided treatment for opioid use disorder across the globe in a range of settings. Generally, this isn't being met, and fewer clinicians said that they were delivering that service in their countries compared to those who thought there was an appetite for it. And this is especially an issue, maybe a barrier in low and middle income countries. Despite current assumptions that you see hinted at in discussions of published literature and in conversations with colleagues, even here, people tend to think that clinician concerns might be a bigger barrier. You're telling us those issues and barriers exist within the systems for prescribing and monitoring and offering appointments and even supervising your practice within your countries and settings. There was a very strong endorsement on the need for some best practice guidance. Hence, we're very keen to follow on with the Delphi study that I'll mention in a second. And as I've highlighted, there were significant numbers, around a fifth of respondents were undecided on the barriers associated with clinical risk, issues of communication online, and impact on your workload. So there are specific gaps in evidence and experience that we can address. So next steps, as I mentioned, the survey is still recruiting. I think we're holding it open till, it'll be closed definitely by the end of this month. So please drop me an email if you want to participate and we'll send you a link. We will provide a more full report on survey findings in the next few months. And there does seem to be an appetite, not only among us, but among our respondents for some global consensus statements on best practice for TMUD. And we need this to be jurisdictionally based rather than global. There's no good one country telling another country how to deliver TMUD if the context of regulation and policy and the legal frameworks are different. We have a Delphi survey developed and ready to go. It'll be quite demanding, taking maybe over an hour to complete, but we shall be piloting that, so watch this space. Things that I'm keen to discuss beyond the 5 seconds I have remaining, let's pick that up over the next 2 days. I'd like to acknowledge a range of organizations and especially our study advisory group. Thank you.
Thank you very much, Joe. And I should say, we really missed Alex Baldacchino here, the past president of ISAM, who had some kind of commitments and he was not able to make it for this meeting, but he sends his regards to everybody here and we really, really miss him. And Joe is one of the PhD students in his lab and we are really happy that we have his team here. So the next speaker is going to be Arash, Dr. Arash Khojasteh Zonoozi, one of the young MDs in our team, and I'm really happy that we have Arash here. Arash, please.
Yeah, thank you a lot. Hello, everyone. This is Arash. I'm a medical doctor, and I'm also working as an ISAM-GEN assistant officer, and I'm so honored to be here today with you. I'm going to talk about one of the other global surveys that we have run through ISAM-GEN, which is a global survey on problematic use of the internet. So I'm going to talk in 4 sections. First, I'm going to define the project, then I'm going to go through the methodology. We insist on methodology because we want to say that how are our surveys in the global expert network working. Then I'm going to move through initial results, and next, the road ahead. So beginning with the project definition, we should be able to first define problematic use of the internet. As you know, we already had a panel this morning talking a lot about problematic use of the internet, how are the complexities in defining this definition. But right now, I want to just point out to one of the papers that has been published in 2022 by Professor Feinberg, Professor Potenza. This is a narrative review on the advances in problematic usage of the internet research. They have provided a table on working definitions of various forms of problematic usage of the internet. As you can see, this includes gaming disorder, gambling disorder, online buying or shopping disorder, cyberchondria, compulsive sexual behavior disorder, cyberbullying, problematic social media use, and social hoarding. But in order to move on and have another overview about the terminologies around PUI, we have a living, ongoing systematic review being conducted by Dr. Mehran Zarabidoki, who's here with us today, and Dr. Mustafa Kamali. And as you can see in this picture, this systematic review shows that the terminology do not overlap a lot. As you can see, we have many publications stating the general PUI terminology, problematic use of internet, but the other terminologies do not really overlap with this general PUI. So this defines that we are still far away from having a consensus on the terminologies around PUI. Okay, I think this is not working. Okay. So moving now to what we defined in this global survey about problematic use of the internet. The first two subcategories are gambling and gaming disorders, which are the only two behavioral addictions that have formal WHO ICD-11 and DSM-5 definitions. It is more complex with gaming disorders in the DSM-5, as discussed earlier today, but we picked these two specifically. As I want to show you, the ICD-11 gaming disorder definition has the criteria, as you can see here. You can see impaired control over gaming, increased priority given to gaming other than other life interests and activities, escalation of gaming despite negative consequences, experiencing significant distress or impairment in personal and other aspects of functioning. Extending the period of the gaming disorder than more than 12 months, and also not being accounted for another mental disorder or being due to other effects of substances or medications. Moving to the three other categories that we have considered for this specific survey, we also chose problematic online shopping, pornography, and social media use, which do not have formal definitions yet, as I mentioned for gaming and gambling disorders. But these are the 5 categories that we have considered for this global survey to ask questions around. So the project's aim was to do a situational assessment of the importance and current state of problematic use of internet and its treatment in different regions of the world. Our esteemed PUI steering committee leaders include Professor Alex Baldacchino, Marc Potenza, Zsolt Dimitrovics, and Hamed Ekhtiari. We also have a group of actually steering committee who are also leading the project and providing their expert opinion on developing the questionnaire and running the whole survey. So now moving to the methodology, we submitted the protocol of this survey with the help of the University of St. Andrews and ISAM's collaboration, of course. The target audience of this survey were ISAM collaborating addiction medicine and psychiatry societies, as Hamed also mentioned in his first slides. We also reached out to our regional representatives to ask for their help in order to distribute the word to the societies in order for them to take part in the survey. The first draft of the survey was then designed. The survey was structured in 4 main sections. We We started the survey with scenario-based questions, which were 6 scenarios, providing each of the subcategories as a scenario. We wanted the participants to get a sense of what we are initially talking about when we say online shopping disorder, when we say online gaming disorder. Then participants moved to the next phase, which was the importance of PUI, interest groups, training programs. The third section was about the health response towards that, and the last was about the severity of each of the subcategories. A big and huge shout out to Joe Schofield with his tremendous help that we were able to actually have the IRB approval by University of St. Andrews. And right now, I just want to give you a glimpse of some of our results. I don't want to spoil the results because the survey is still ongoing and we are still reaching out to societies for more responses. But till now, we have 29 out of the 49 societies in our network participating in this survey. As you can see, we've started reaching out late July, and we have sent 3 reminders till now, till mid-August. So at the first round, when we reached out, we just had a response rate of around 8%. But then we insisted and we moved on with further reminders, and we engaged the ISAM Regional Council representatives, which helped us to gain around 60% response rate. And now moving to the scenarios, as I said, we had 6 different scenarios for the participants. I'm just going to go through one of them in order for you to get a sense of how we designed the questionnaire. I'm choosing Alma, which was the general PUI scenario, which was a 25-year-old female who worked as a software engineer in a multinational company. She spends most of her free time on the internet, browsing social media, playing online games, watching videos, general internet use. She often stays up late at night, neglects her sleep, hygiene, and health. She has lost interest in the things that she has used to enjoy before. She has become distant from her family and friends. She feels anxious and depressed, fantasizes about being on the internet when she's offline. She cannot reduce her internet usage, although she has tried several times to quit. She already feels guilty about being online in that amount of time, and her work performance is also reducing. So this is the case that the participants were presented with, and then we
Arash, let's just make it just pretty engaging for people.
Yeah,
so
sure.
we have a case of problematic use of internet, and do you see these patients in your clinic, in your addiction psychiatry or addiction clinic? Christian, do you see patients like these scenarios? Who sees patients with these scenarios? Goodman, do you see patients with these scenarios? No. Okay, so there are people who are, okay, so, okay, so, okay, exist, but you do not see them in the clinical. Okay.
Yeah. Yeah, shall we? Okay. So after
Tell you, Hamid, in our staff, we've had to make our lunchroom tech-free because of this reason.
Oh yeah, yep.
So no phones allowed at
We
lunchtime.
already have people here in this room that they have the same issue. So it's pretty frequent. Yep.
So after facing that scenario, people were asked 7 series of questions. First, how frequent is the scenario that you've seen? Then, who initially visits the patient? Afterwards, who will ultimately provide the final care? What treatment settings are available? What treatment options are available? And how do you evaluate the expertise of addiction workforce in managing such scenarios? And in a general form, how do you evaluate the capability of your country's health system in managing such scenario? So all the 6 scenarios, all these questions were repeated.
And so these are the surveys, and I already have Dave Martel here. Dave, we are waiting for your responses from Canada. So we are basically asking societies right now in terms of what is actually happening. And even kind of sending those surveys for people is just get them engaged in terms of asking, do we have any services for cases like this in our region? And if somebody, these are the challenges that people are facing around the world, right? Please.
Yeah. So as you can see, it appears that most of the organizations responded that the frequency is it's frequent or occasional, which means probably most of the people who has responded to the survey has said that we have this type of patients. And it appears that the initial visit is mostly done by a GP or family physician and psychologists, and then they're mostly referred to ultimate mental health care professionals, as you can see, psychiatrists, psychologists, and addiction physicians. And the most treatment setting reported is, it appears to be outpatient long-term settings, which I will also dive into this more deeper later. So in terms of the expertise of addiction workforce from the opinion of the societies, it appears that there are some levels of expertise, but around 45% appear to be novice or beginners in managing such scenarios from the point of view of the societies. Same goes for the health system capability somehow. Regarding the treatment options available for general PUI, as mentioned earlier before, we have randomized clinical trials for CBT, some trials for pharmacological therapies, and it appears that mostly have reported that CBT and pharmacological therapies are the most treatment options available. Moving to the next phase, to the next section, we asked about importance of PUI. So the scenarios are now closed. All those 6 scenarios, people were asked about the same questions. I'm not going to go through all the results. The second section, we asked about importance of PUI. Are there any interest groups available? Any training programs? Any specific certifications around PUI? How do you evaluate the severity of PUI at the current moment? And how do you estimate the severity in the next coming 10 years? Are there any research development programs available? And at last but not least, are there even any investment plans for education and development of PUI as a clinical field? So moving to the results, it appears that most of the participants think that the research and development importance is very important to extremely important.
And the participants are societies, so there are addiction medicine, addiction psychiatry societies in different countries, as you can imagine, how we can get them engaged in that process.
Yeah. And the current severity importance is also, like around 70% have responded that it's very important or extremely important, but as you can see, they have estimated that the futuristic severity importance in the next 10 years will be much more. Regarding the programs available, there appears to be no much certifications around PUI, but there are available interest groups, but it appears that the next step has to come, and we move from interest groups to more programs and certifications as the societies have reported. Then we asked about awareness around PUI. How much are the addiction experts aware about this situation? And on the other hand, how much is the community and the public aware about this? Obviously, the experts are more aware, and some 8 of the participating societies has reported they are fully aware about the situation, and nearly around 70% are aware of the situation, but the community's awareness is not that much high. We could also think about it. Moving to the next question types, we asked about health response towards PUI. Are there any specific treatment programs available? Any specific expert awareness programs available? And specific general educational programs for the community available? As you can see, we asked societies to tell us about these questions if the program is available nationwide or it is available but not nationwide. As we can see, for example, for specific treatment programs, we only received available nationwide programs from China, not any other countries right now. And for the expert awareness program and general educational programs, almost goes the same. So what are the available treatment facilities for PUI from the opinion of the addiction medicine societies? We asked this through online short-term, outpatient, residential, inpatient programs, and the long-term same programs from the societies. As I mentioned in the scenario questions, the results are repeated again, and it appears that short-term outpatient settings and long-term outpatient settings are reported to be the most available settings for treatments being received with the people who are dealing with PUI. And last but not least, we asked about the severity of distinct PUI branches, each of the 5 domains that I mentioned at the beginning, from very mild to very severe. And this is the results, showing that it appears that gambling severity from the eye of these addiction societies seems to be very more, like 8 societies have reported very severe to severe problems with gambling. Next comes social media severity, and the least is shopping severity, online shopping severities. So this is just a glimpse of the results. We have many more things to report, but due to time and as this survey is still ongoing, I'm not going to just give you more details here right now. So what happens now? The point is, we didn't just intend to collect data while running this survey. We were thinking that this program will bring awareness around PUI among the addiction workforce. Right now, we have conducted this survey with these societies, addiction societies, but we are planning to move this and run this survey with around 450 addiction individual experts in our networks from around 93 countries. And we believe this can help spreading the word of the problems around PUI within the addiction workforce. We are still waiting responses from the countries whose flags are here, as you can see, so please reach out to us and we still wait for your responses. But there are other countries whose representative of addiction societies are also in the room, can also contact us and participate in the survey as well. And we will start receiving responses by the end of September 2024. And thank you very much.
Thank you very much, Arash. As you can see here, I mean, how we can use a global network that we developed to have an idea about what is happening in specific areas. And not only kind of having an idea, also increasing awareness. When you send these scenarios and people read this scenario, they start to think, okay, do I have patients like this in my clinic? And they start thinking about, okay, do we have any specific program, training programs to be able to manage case scenarios? And definitely, addictive behavior is going to be an important part of addiction medicine for the next decade. So we definitely need to invest on that specific line. Now we have 2 remaining speakers who are going to talk about 2 other initiatives that we started. We do not have data yet, but they are going to engage you on those 2 new initiatives. One is about comorbid psychosis with substance use disorder, and also comorbid PTSD with substance use disorder, and treatment services that we have available around the world. So the next speaker is going to be Dr. Christian Schuetz. Christian, please. So we will have Christian presenting about the comorbidities, dual psychosis comorbidities, but I want to emphasize that that is an open door for others to come join the already existing working groups or shaping new working groups within the community that we have. Christian, please.
Thank you, Ahmed. Actually, to start out with, the name of the group has been changing, and so it has had different names, but I think we should go to psychosis and substance use disorder. Actually, Marc Potenza was the one who has been pushing for addiction as a name, not substance use disorder, because addictions does include substance use disorders. And all the other groups have started with substance use disorders and then the concurrent disorder and have then moved on, added substance use disorder. So we'll change the group to that. We do know that actually concurrent disorders are a huge problem, but the question is how much of the problem is and what is available in different countries. We have a lot of comorbidities, but the comorbidities between substance use disorder and mental disorders is based on that in a lot of countries. These are quite separate systems. So, 2 years ago, I actually stumbled in a meeting like this, and I had no plans for whatsoever, and I made the mistake of talking to Hamid, and Hamid is very enticing. And when I left the room, I had agreed to do a survey on concurrent disorder. So just to say that he also had promised that I would get a lot of support with that. And you know, When people want you to join a group, you always get you'll get a lot of support. But it actually was the case. It is run, these surveys are really run a lot like startups, I think. You get very uncomplicated, easy support, and I really have to thank for that. And I think it's very encouraging to do this. And sorry, going the wrong direction. Why did I choose this specific topic? Actually, psychosis and concurrent disorder are quite common, more than people often anticipate. This is from a Danish registry, and they had a little bit over 100,000 individuals here in this survey on substance use disorder, and 16,000 of them actually had a diagnosis of schizophrenia. If you turn it around, among those with schizophrenia, also 16,000, that's the overlap, had substance use disorder. So this is not a small group. And WHO, for example, also has been acknowledging that they have done a lot in a lot of different fields, but very little on psychotic disorders. Why do I think this is important? If you look at concurrent disorders, I always push the wrong direction. What you can see here is a list of the nature and prevalence of combinations of mental disorders and their association with excess mortality or reduction in lifetime. And what you can see in red is the combination of substance use disorders and psychotic disorders. And what you see is they stick out. They stick out in that the reduction of life expectancy is by far the largest if you have these combinations. There are other additional diagnoses here. They had 7 categories. So adding another category did not really make a big difference, but the combination of these 2 groups of disorders really had the highest impact on the life expectancy, the mortality, and also the life quality of the individuals. And we know there's very, very little out there. At least that's what we want the evidence for that. Psychotic disorders is more than schizophrenia. For a psychiatrist, this is pretty clear, but we had to explain that a little bit in the survey. We met first in 2023, August 23, we put together a group, and then in 2023, that's the group, that's the advisory group we had put together at the time. We came up with a first survey, and they actually had about 4 iterations where the members would go over the survey and we would improve the surveys to the level that it is acceptable for different groups in different countries. During the meeting with the regional council, there came a suggestion to have it translated into different languages. By now we have available French. Michael Bish, I think, made the translation. I don't know, he was here. Spanish and Arabic. But we welcome any additional kind of translation, because the feeling was that if you have the survey available in the native language from different countries, it might help to get more responses, and you really have less of a selection of individuals who are internationally oriented and speak fluently English. The survey is 2 pages. This is what the survey looks like. It is now, actually, we do have approval from UBC. It's ready to go. We will send it out soon. This will be available as on a computer, or you can fill it out actually also on the iPhone or handheld. We had to have the logo from UBC on it because we did get the approval from the University of British Columbia for the survey. And I actually welcome and try to motivate people to answer that survey so that we get a better overview of what is available. We have a number of questions regarding specifics of availability for individuals who suffer from both psychosis and from substance use disorder. We have 2 scenarios which are very short to kind of like get an idea what would be happening with an individual who had this issues. So the next step is then in Hamburg, we hope that we will have the results and can present the results. Actually, it should be quite easily the case. But the idea behind this first survey is not only that we want to get an idea of what's available out there globally, but also kind of like what can we do as next steps. The idea is to develop something of a network of people who are interested in the topic and utilize the survey as a first point of developing this network. We have not decided within our group if we want to go with a Delphi request or Delphi survey in trying to understand what would be helpful in developing a kind of like interaction or a intervention. But this is something which we definitely plan to do, and where we see the survey as the beginning of a network in the end, a network of people who are interested in the topic and who are helping with education and with kind of implementation, and also providing support in making problems visible and make people aware of it. I do have a product placement. I have to apologize for that. Actually, we do have a free online course we developed in the last 5 years with a large group of people for training of frontline staff for concurrent disorder. It has 4 levels of expertise, from low expert to high expertise, and it's a free training. Please feel free to utilize it, because currently we have the funding for it, and we need to utilize it, and otherwise the funding will not continue. So this is, I think, an opportunity for people looking for training for their staff. Thank you.
Thank you very much, Christian, for the great presentation.
Oh, I can put it back, yes.
And we can move to the next speaker, and then we can have the discussion and of course Q&A. So the next speaker is going to be Dr. Denise Hien from Rutgers. Denise, please.
Thank you so much, Hamid, and everyone for staying for our presentation. I'm pleased to be here in place of Dr. Carol Weiss and Shalini Arunagiri, who are leading the PTSD and SUD ISAM-GEN group, but I'm going to spend a few minutes talking about the status of the group, also in the effort to have those of you who might be interested in joining it. I myself am an ally of the group, and I'm a member of a couple of different international trauma societies that I'm assuming will become participants in the survey once it moves forward. So I just got to know about it this past year, but I just want to say as an outsider, I really have been impressed with Dr. Ekhtiari's efforts to move to a global and an international position in relation to creating these scholarly communities. And the COVID happened, and there were all kinds of negative consequences that we experienced in our research, but some of the silver lining and upside have really been kind of recognition that we can connect with each other all over the world in ways and do powerful things. So I congratulate you guys on this. And just to give you a little bit of an update, and by the way, Carol Weiss, I believe, is somehow a participant in this session. She figured out a way. I'm not sure how that is, whether we'll hear from her or not, but in any case, she's here with us, not only in spirit. But the PTSD-SUD survey work group was created, I believe, sometime last summer, and the work group members that are part of ISAM are listed here, and some of whom you've heard from today already, as well as Shalini and Carol, who's leading the charge. And then Carol reached out to me and a number of other experts from all over the globe, and I wish we had the little, icons of everyone's faces, but we will have them next year, I'm sure. But this is a representation of the international field of trauma and addiction experts. And where we are in terms of the survey, and before I go into that, we just had a panel earlier today on PTSD and substance use disorder, and I don't know that I need to say this, but in terms of the epidemiology, this is a worldwide concern, very high rates of trauma exposure. Certainly we're aware of the global context of war, famine, climate-related trauma, and many other kinds of traumatic stressors that can lead to post-traumatic stress disorder, and then one of its consequences, which is the use of substances, and with a clear neurobiological underpinning. And so that's why it's really important for us to know more and to engage more across the world, particularly because most of the research that we've done is in higher, middle, and not in lower and middle income countries. So in any case, the survey, we're following the model of the previous surveys that you heard, and apparently St. Andrews is a gift that keeps on giving because we are awaiting IRB approval, but the survey, which has been developed over the course of the past year, there are 28 questions. It'll take 10 to 15 minutes for providers and organizations to complete. We are also refer to the DSM and ICD diagnostic criteria of PTSD and complex trauma, and we also talk a lot about the different kinds of treatment approaches, behavioral interventions, and as well as, so there are 6 sections. We did not include cases. I don't remember why, but there was a rationale behind it. And these are the, sort of similar to, I think, what we've heard from the other surveys, demographics and description of the clinicians and the work settings, what kinds of screening and assessment tools and treatments are available in the settings or from the organization's perspectives, awareness of PTSD and substance use disorders, familiarity with specific treatments, and then specifically with integrated treatments, and then country-specific treatment availability. And basically, I'm just showing you pictures of the consent form, as well as the fact that, yes, in fact, we do have a survey, and here is what it's going to look like. It's been programmed into Qualtrics and had gone through several tests. We've been testing it, and so as soon as the IRB approval is ready, we will be ready to go. And I think that's it. Thank you.
Thank you very much, Denise. Could you just join us in the panel here? So other speakers, Christian, Arash, Fateme, would you just join us? And Joe, you can just have this. And we are here to take questions, so please do not be shy. And whether you have comments or questions, we like to have your ideas. Please.
Thank you, everyone, for your presentation. Some amazing work. And it's really great to be able to access the process that I know has been developing over the past couple of years or so. I just have a question around the term expert. And perhaps we see ourselves as members of ISAM as experts, but there's another group, which is people with lived experience. Is there scoping to start including that bit of expertise so that we have more of a sort of co-design approach to it?
That's a really good question. Right now, the structure of the ISAM Global Expert Network is designed initially based on frontiers in addiction medicine clinical practice. So those who are actually seeing patients, and they are in the first line of interacting with patients. So that is the initial design. based on the nature of ISAM, right? I mean, in ISAM, we are a group of physicians who are working in the field of addiction. So that is the initial design. Then we extended that to addiction medicine, addiction psychiatry societies. And now we are thinking to extend that to addiction treatment centers. So if Dr. Zonoozi here has a center in Kabul and they have 100 patients in their center, they can be one of the members of that network. And then I can ask Dr. Zonoozi, how many of your patients have this specific issue? And they can report about the status of that specific problem in their center. So that is the third level. But the fourth level, as you said, I mean, we can think about, and there are already some expert networks with people with living experiences with drug use. We need to think about that. And you are one of the ISAM board members, so we need to think how we can make sure that their voices are going to be heard and how we can engage them in the community. And honestly, I do not think that, at least in this meeting, we had any of them involved and giving us feedbacks. This is what we are already doing. I mean, in ISAM meeting in the US, in CPD meeting, we invite them as a part of the community. But ISAM needs to think about whether we want to kind of engage them in that community. Any other suggestions from the colleagues in the panel? What is your experience? Can you just help us with that? This is kind of...
Hello? Yes, I think one thing to keep in mind is that this is initiated on a shoestring, I think. And so you need to work with people who are quite responsive and who are willing to kind of like just get involved. And I think when you do this with groups which are not, for example, so attached to a system and with a very different background, then it becomes much harder to build something like this in a time. Obviously, this is a goal, but I think just what already has been achieved so far is immense in that short time, and I think that would take a lot more work.
Joe.
Thank you. I think there may be a case for having a discussion within ISAM-GEN about whether to have a specific survey in the future on how do the ISAM-GEN members and societies engage with civil society? How do they involve patients? I can see why people with lived experience aren't experts in the definition of ISAM-GEN, because that's a specific group of people with specific skills. But we should be surveying members on how they engage with civil society individuals, families and societies.
Susan, do you have any suggestions yourself? Yes, please.
I was just going to add one thing, which is that I think as ISAM-GEN kind of grows and more groups are developing on whatever specific areas, I would recommend, in response to your great point, that the expert group include individuals with lived experience that are informing and what we call co-producing, involved in the vetting of the surveys and the determining of the questions that are being asked, and there are a lot of individuals with lived experience who also work in addiction communities, and so to include them as stakeholders in the process would be one way of doing it, and I think they will be very excited to be engaged and involved.
Absolutely. Arash, you have any? Yeah, and the process of co-development is, something that the posters that I was showing you, everything that we develop, or even when we want to start a brain stimulation study, we usually invite people from the community and ask them, does it look good? What is your thoughts about that? So without the co-development process, even when you talk about advanced technologies, it's going to be very complex to make sure that we are able to use that in the community in the future. Arash, please.
So just a quick comment that the good news is that we're moving towards developing the ISAM portal, in which we are hoping that we can engage people in different subgroups And right now, the process flowchart that Ahmed showed in his initial slides shows that we did recruit experts with snowball sampling. At the first, we had some databases, we reached out, we had a list of criteria, which is mentioned in the ISAM-GEN protocol paper. You can refer to that for more details. But hopefully the good news is that we will be able to have other subgroups which will contain different experts in different fields in addiction.
Thank you for all the responses. So how about I propose this, Hamed? So I'll lead one that would involve co-production, and I'd like a co-chair, please.
Absolutely, yep. You're assigned right now, just, yeah, very fast process. And thank you very much, Susanna, for volunteering, helping us with that process. Dave, please.
Dr. Ekhtiari, I think I'd like to start out by acknowledging that I was publicly shamed for not filling out my survey that was sent to me, and I tried to capture the QR code, but the slides went too quickly. So if you put it back on the screen at some point, I will fill out my survey. My question is a simple one. It's I wondered about validation. I know it's an enormous task, but these surveys, they rely on the way the wording is in some of them on people filling out the survey reflecting on a jurisdiction. For me, when I filled out this first survey in the series, I was mindful that for a lot of the questions, my answer was, well, it depends. And how do I decide, this is a black and white answer you're looking for, it's not a Likert scale. But I also wondered, do I really know? And if a researcher did a Google search, is this available in Canada? It might come up with a very different reflection. Is there a process of validation built into these surveys?
That is a really, really good question, and I think that is going to be an ongoing process. I'm not sure, have you done the simple self-reports that we use in everyday clinical practice? Something like PHQ-9, BEC. When you do even those well-validated surveys, sometimes when you want to go through them, sometimes you feel, okay, it depends. I mean, even when you are reporting about yourself and you have a full knowledge about yourself, some of those surveys you feel, okay, it depends maybe sometimes. So I mean, that is the nature of self-report, first of all. Second, we are asking about people's perception about what is actually happening. So that is one of the other kind of essences in those surveys. We are asking clinicians about what they perceive as what is actually happening. So there is always a filter of their perception about the reality, and this is not the actual reality. We believe that even those perceptions would be valuable, but we need to always kind of consider that. Sometimes when we run surveys in some African countries that we know, or some other countries that we know that they do not have that much, but there are people who are really positive. And they report, okay, I mean, we have something and there are things, but I mean, there are some European countries that we know that they are sometimes more negative in terms of, okay, no, the system is not that good. And so you see that level of perception is always involved. So we always take those things with a grain of salt in terms of we know that we are talking about the perception of what you perceive. But even with those filters, we feel that the data is still valuable. So you can have a sense about what is actually happening, while you feel that there is always a limitation in that process. Any other suggestions from the panel members? And the other thing is, for right now, the surveys that we showed are being organized or being kind of asked from the societies. But now we are also moving towards running those surveys in the expert networks. And for example, from Canada, we have 30, 40 experts. So sometimes when you ask from a large group of experts and then you put them together in a collective way, then it might be a better reflection of the reality. And when you basically put them together and you have a sort of a collective data, that might be potentially a better representation.
I have a reflection, but I'd like to hear from what Christian
Christian, please.
Okay. I had the same concerns as you had when I started out. So the first step, what I did is I really tried to screen and ask around if there's anything I can base it on, I can use, if there's anything similar available, which was not the case. I asked, I have, for example, Linda from the European, what's it called now, Drug Use Agency, who does a lot of these international surveys, and she also said there's nothing available. So then I did kind of like come up with the questions. But we had a number of iterations, and people from different countries, I had the list of people, it was from each continent, we had representation, did go through the questionnaire and came back with comments. I know that this is kind of like a pretty much a crude process, but I think in principle, one thing again is that we are trying to get started and trying to get going, and one thing, perfect is always the enemy of good, right? So that I know this is kind of like a little bit the standard you want to have for a clinical questionnaire or something like this. But I think it's a first step, and if you would have a validation process, it would be quite a substantial process to complete that before you could go get started, right? So it is a limitation, yes.
It'd be certainly fascinating, but as Ahmed was reflecting, the gap between perception and reality, it struck me that wouldn't it be interesting not just to collect data from care providers who think they know maybe the lay of the land in terms of what's available, and then to, from the same jurisdiction, ask people who need the service, what is their perception of what's available, to measure that gap. I'd be interested to see that. Anyway, thank you.
Absolutely, and that's basically the reflection that Susanna was mentioning in terms of bringing those who are actually using the services in that process. And it might be interesting because, I mean, the system that we have developed right now for addiction is new in our field, but this is a methodology that people have been using in areas like politics and ecology and environment change. And they develop specific methodologies to, over the time, to validate the surveys and also make sure that when we have a responder, over the time they can even evaluate the quality of responses of that responder. So even they add specific components to the survey, they add specific vignettes in the surveys to just make sure that they increase the validity, and also they can check the responses of specific responders to the actual reality. And so there are specific methodologies to increase the quality, and we are getting there. So we had a specific workshop, and we invited experts from ecology, from politics, from many areas that they have never heard about addiction medicine as a discipline, and putting them together. And we learned a lot in that process, but there are still many things to be done in that process. So I think that we are done. Okay, yeah. So yeah, we are passing. We can kind of continue the questions after the session. So we are just 1 minute kind of ahead of the timing of the schedule. We are going to have a keynote speaker right now. Who is the keynote right now? Okay, you are going to be the keynote speaker. So hopefully we are not going to eat your time. So Raju, we can just continue discussion afterwards. But thank you very much for joining us, and we are here to extend the interactions. Thank you very much.